again going ahead with our neural system and examination of the critical illness with respect to the nervous system. Critical illness, polyneuropathy and myopathy. Why exactly this polyneuropathy and myopathy sets in, and what are the investigations, diagnostic evaluation and management per se of this problem. So going ahead, what exactly is this polyneuropathy and myopathy? It was first described by Bolton and colleagues back in Central Institute and in 1986 of polyneuropathy. So ICU-acquired weakness, that is ICU-AW, has classified and given a definition of this polyneuropathy and myopathy, that it is a clinically detected weakness, specifically in critically ill patients who are admitted, who are ICU admitted, and in whom there is no plausible etiology other than the critical illness. So apart from the patient being critical, the other cause of weakness is not being able to be elicited. What exactly is the cause? So most probably, this is a ICU-acquired polyneuropathy and myopathy. So ICU-AW has further classified it into a CIP and CIM, that is a critical illness polyneuropathy, CIP, and a critical illness myopathy. Further subclassified into cachexic, thick filament and necrotizing myopathy, and critical illness neuromyopathy. So three basic classifications that has been given of this polyneuropathy and myopathy. The first is CIP, the second is CIM, and the third is neuromyopathy, that is CINM. Myopathy is further divided into cachexic, thick filament, and necrotizing. So this is the standard classification. So muscular weakness, specifically for a patient who is ICU admitted or a patient of critical illness, is not something very new. So when we deal with a patient of critical care and you see who is prolonged bedridden, who is immobile, and he is there for a long period of time, so that muscular weakness, becoming cachexic, losing a lot of body weight, protein loss is being there. So development is not something new. It was first described by Astor scientists back in 1892. So weakness is partly as a consequence of improved survival with MODS or sepsis, but may be associated with treatments that is administered in the ICU. So when we talk about the neuromuscular weakness in the ICU, it is most often due to CIM, CIP, or a combination, that is CINM. So basic classifications which we discussed. So over the past 2 decades, improvement in survival after the discharge from the ICU probably have led to increased awareness. Most probably until date, many of you see that, this ICU-acquired weakness still in many of the hospitals and diagnosis, sometimes it is being missed. But again, with as improvements in the new technologies, new methods have come in, and the patient's mortality has decreased, there are improved chances of survival after discharge. So this has raised the awareness for this ICU-acquired weakness. So the magnitude of neuromuscular impairment in the increasing population undergoing post-ICU rehabilitation has now come to the attention of not just healthcare providers also, but also of the patients and families. So when we talk about ICU-acquired weakness, the prevalence is, look at that prevalence, almost close to 50%. That means every 1 out of the 2 patients is developing this acquired weakness, whether a polyneuropathy or myopathy. So close to 50%, according to a study. Prevalence of a myopathy that is being there is found to be almost 70% in a patient of sepsis or SIRS, severe immune reconstituent syndrome, or if ICU stays greater than 7 days. So almost 70%, 7 out of 10, and greater than 7 days if a patient has an ICU stay. So critical illness myopathy prevalence is 70%. 100%, look at that, almost 100% when sepsis is accompanied by multi-organ dysfunction. 7% in a case of orthoptic liver transplantation, and 36% in a case of status asthmaticus and severe acute COPD exacerbation. So these numbers are definitely a alarming number when we talk about, because These are greater than 20, 25, even greater than any of the 5 to 10%, 70%, 100%, 36% in acute exacerbation of asthma and COPD. So what are the risk factors of this critical illness, myopathy, critical illness, polyneuropathy when we talk about? So there are clinical risk factors and pathophysiological features of CIP and CIM. So female sex, again, critical risk factors, sepsis, catabolic state and multi-organ failure, severe inflammatory response syndrome, SIRS, long duration of mechanical ventilation, immobile, a patient is a long immobile patient, a multi-organ dysfunction that is either a renal or a hepatic cause, hyperglycemia, a patient on long-term glucocorticoids and patient on neuromuscular blocking agents, patient even on parenteral nutrition, vasopressor support, hyperosmolality and low serum albumin. So if the patient is falling into these categories, sepsis, SIRS, MODS, more sugar levels, the patient is on a long-term parenteral nutrition, corticosteroids, and long-term neuromuscular blockade to paralyze or to sedate the patient if the patient is on any mechanical ventilation, if it is a long duration. So this increases the chance of CIM and CIP. So what is the pathophysiology? What exactly happens in a case of polyneuropathy and myopathy? There is a critical illness of the condition, and as we all know, that in critical illness, there is a lot of cytokine production. We have seen this. So what exactly happens? Electrical alterations, there is a lot of microvascular changes, metabolic, electrical, altered calcium homeostasis, there is bioenergetic failure. So what is the electrical alterations? That is the electrical, there is nerve membrane depolarization. So because they are the electrical circuit, and because of that nerve membrane depolarization, there is critical illness polyneuropathy. And because of that CIP, because of the nerve membrane depolarization, that leads to denervation of the muscle, because all the nerve fibers supply the important muscle, and that also triggers the central illness myopathy. So you see this, how CIP and CIM are being related. So if there is a nerve membrane defect, that triggers polyneuropathy, further leading to muscle denervation, further leading to CIP. Now, what are the microvascular changes that occurs? There are vasodilatation of the vessels, permeability is being increased, and because of that, there is passage of neurotoxic factors, again, extravasation of the leukocytes and cytokine productions, and there is edema accompanied by hypoxemia. So what happens? Again, CIP, muscle denervation, again, CIM can be there. When we talk about the bioenergetic failures or metabolic alterations, there is hyperglycemia. That the hyperglycemia, as we know, the more the amount of sugar or the glucose levels in the body, that leads to increased generation or decrease the scavenging reactive oxygen species. So because of the decreasing free radicals, there is mitochondrial dysfunction that further triggers the CIP and further triggering the CIM. Electrical alterations, like there is also inactivation of the sodium channels that lead to inexcitability of the muscle membrane, another triggering the critical illness myopathy. So altered calcium homeostasis, there is changes in the excitation and contraction coupling that occurs of the sarcoplasmic reticulum, thereby leading to CIM. Some other metabolic alterations like apoptosis, increase in apoptosis, reactive glutamine deficiency, increased activation of the proteolytic pathways that is being there. All this together leads to protein catabolism, and because of that protein catabolism, protein breakdown, that leads to critical illness myopathy. Along with this, if the patient is on, neuromuscular blocking agents or corticosteroids, that also triggers the muscle denervation and critical illness myopathy. So this is the overall pathophysiology that leads to CIP or CIM in the patient of a critical care. Critical care polyneuropathy. So the second neuromuscular condition, that is of course CIP. CIP appears to be a common complication of severe sepsis, and why it occurs, thought to represent a neurological manifestation of the systemic inflammatory response syndrome. So when we talk about the neural or neurological manifestation, there is electrical disturbances, there is electrical alterance that occurs. And why there is that electrical disturbance that sets in? Although the mechanism of axonal injury, the mechanism of axon or mechanism of neuronal changes or neuronal injury in critical care polyneuropathy is unknown. However, when we talk about the various theories that are being linked to the injury in CIPs, injury of the microcirculation of distal nerves, that leads to ischemia and axonal degeneration. So this is the overall pathophysiology. Clinical features when we talk about CIM. So CIM can occur critical illness myopathy on several days, whereas CIP takes 2 to 3 weeks. So probable, clinical features or patients that sets in failure if you're not able to wean off a patient from the ventilator is the weakness in the absence of any unexplainable, in the absence of unexplainable pulmonary pathology is a very common presentation. So if there is a no pulmonary pathology, try to understand this. The patient is not having any pulmonary pathology, and even if he is on ventilator, and apart from that pulmonary pathology, the lungs appears to be normal. The parenchyma of the lungs is normal. The pleural cavity is normal. CT scan probably shows you a patient having a normal lung structure, but a ventilator patient, despite having a normal lung, is not able to be weaned off from the ventilator. So think of the other causes. Ring in your ears, ring the bell in your brain that the patient is not able to wean. Why is not able to wean? We are saying that the weaning is failing. Why weaning is failing if the lung parenchyma is normal? So it can be a CIM or a CIP. So distal and proximal flaccid muscle weakness, symmetrical, although isolated limb weakness has been described. So DTR, deep tendon reflexes, can be absent. So unlike CIM, CIP can have distal sensory involvement, often difficult to test since many patients are encephalopathic or under the sedation. Facial and ophthalmic muscles are spared most of the times, but if cranial nerve involvement occurs, Guillain-Barré syndrome should be ruled out. So it is not just your weaning is failing, you're taking all the efforts, you are switching back to the modes, you're switching back to the, TPs going ahead, and again, you're switching to the non-invasive mode. So cranial nerve involvement occurs, think of a GBS, yes. So for patients with CIM, sensation should be normal if it is tested reliably. So patients should be at least grimace to the pain stimuli even when they are encephalopathic. So a combined CIM and CIP clinical features that overlap the individual but closely corresponding features of CIM and CIP are being present. So for specifically for a patient of CIM, at least a grimace response, a bit of, facial expression changes to the pain stimuli, even if they are encephalopathic, has to be there. CIM, the most common form of ICU-acquired myopathy is CIM. It is more than CIP. So also known as acute quadriplegic myopathy or thick filament myopathy. So we talked about the three classifications of CIM. So the major histopathologic findings in a critical illness myopathy is selective loss of the myosin, which is the muscle filament, and which can be identified due to lack of reactivity to the myosin ATPase in non-necrotic fibers. So there is usually a atrophy of the myofibers, which we talked about, type 2 versus type 1. And because of this atrophy, there is selective loss of the myosin and lack of reactivity to the myosin ATPase. So myofibers are basically the multinucleate cells that are being formed by the fusion of the myofibroblast during the development. So inside each myofiber, there is myofibrils that are the long threads that run lengthwise. There are sarcomeres, repeated functional units of the contractions, and there is actin and myosin. So actin is the thin filament and myosin is the thick filament. So what happens? There is loss of that selective loss of the myosin, that is the thick filament, can be identified as a lack of reactivity to myosin ATPase. CIM increases, CIM risk increases with the duration of neuromuscular block So as soon as you are more trying to paralyze the neuromuscular, especially in case if the patient is on ventilator and you have put the patient on neuromuscular blockade agents, so more and more you are trying to paralyze the respiratory muscles or muscular block is being applied, there are higher chances of CIM. So neither the type of neuromuscular blocking agent nor the corticosteroids are the independent risk factors for the development of CIM. So they don't just act in a independent. When we talk about the etiology, there are multifactorial etiology and exact etiology of this CIM is being unknown. But again, high incidence in patients receiving large cumulative doses of steroids and neuromuscular blocking agents are employed the important risk factors for the development of CIM. Again, going back to the pathophysiology slide, if you can see this, high doses of steroids, neuromuscular blocking agents, how they trigger the muscle denervation and how they leads to critical illness, myopathy. So usually received greater than 10 gram of the hydrocortisone over a 1 to 2 week period and neuromuscular block for 3 to 5 days is recognized as an important risk factors. So when we talk about the overall risk factors for CIP, CIM and CINM, that is the clubbing of both these. So probable risk factors we have discussed: severe sepsis, MODS, patient on prolonged ventilation, increased duration of SIRS, increased duration of MODS and hyperglycemia. The probable causes: age, female, gender greater than male, severity of illness, admission criteria according to the Apache 2 score, patient on parenteral nutrition, renal replacement therapy, vasopressors, corticosteroids, parenteral nutritions, and aminoglycosides are the probable risk factors for the development of this CIP, CIM, and the CINM. So when we talk about the pathophysiology of polyneuropathy, CIP is the manifestation of peripheral nervous system organ failure resulting from systemic inflammation. We have talked about SIRS. So see, these include what? There is reduction in the supply of nutrient and oxygen delivery to the nerve axons. Why? Because there is microcirculatory dilation, there is hypotension, there is impairment due to myocardial depression. So because of every of these phenomena, there is reduction in the oxygen and nutrient delivery to the axons. The second is microcirculatory impairment. Why? Again, because of the increased permeability, tissue edema, vasodilatation leading to shunting, and endothelial dysfunction with increased cellular adhesions, molecules, platelet and coagulation system activation, resulting in blockage of the lumen. So because of the more coagulation, more deposition of platelets, there is luminal obstruction that leads to microcirculatory impairment. Another cause is impairment of the mitochondrial oxygen utilization, which we know that is the powerhouse of the cell. And because of that impairment of the mitochondrial oxygen utilization, ATP generation is also hampered, and reactive oxygen production and inhibition of the mitochondrial respiratory chain function is being there. So other postulated mechanisms that can be there: a low molecular weight neurotoxin that injures the nerve axon, possibly lipopolysaccharides and IL-2R molecule. Hyperglycemia itself is a big risk factor that can cause axonal injury. How? Through glucose cellular toxicity or leading to increased oxidative stress or leading to increased oxidative burden. A functional component with neuronal membrane inexcitability through inactivation of the sodium channels can also be the cause. Now coming to the CIM, the main pathophysiology, the main postulated is the reduced muscle membrane excitability. Going back to the pathophysiology, so the skeletal muscle has reduced membrane excitability. How? There is a combination of the depolarization of the resting membrane potential, that is the RMP, and inactivation of the sodium channels. There is even alteration of the sarcoplasmic reticulum function, myosin, less myosin, thick filament. So reduced uptake, release of calcium producing, and decrease in muscle contractility, because we know that uptake of the calcium and release is an important factor which play a role in muscle contraction. Decreased contractile protein function, myosin and muscle fibril fourth generation. So these are the important pathophysiology. Mitochondrial dysfunction and bioenergetic failure, which we talked about, reduction in the mitochondrial enzyme activity and respiratory chain function, muscle denervation either through the neuromuscular block or more increased intake of corticosteroids. So sensitizing them to the deleterious effects of the corticosteroids. So receptors, specifically with receptors within the myocytes, due to increased expression of corticosteroids, more the intake of corticosteroids, they make these receptors sensitized to these increased intake of the corticosteroids, and because of that there is a deleterious effect that leads to muscle denervation that further triggers the CIP and further triggers the CIM. So during critical illness, there is marked atrophy that occurs in about 3 to 4% decrease. You look at that, 3 to 4% decrease in muscle cross-sectional area per day is a big change. Per day. Why? There is protein catabolism, there is proteolysis, there is muscle breakdown, decreased protein synthesis, there is no buildup of the protein, there is no buildup of the new muscle, and because of the scavenging effect, there is increased apoptosis. So because of the muscle atrophy, there is a lot of breakdown. Early decline in muscle strength, predominantly due to the functional changes. There is muscle membrane inexcitability. There is decreased contractile protein function, altered sarcoplasmic reticular function, and mitochondrial dysfunction. So long-term weakness, predominantly due to the structural changes, along with the marked muscle atrophy, can be seen. So now coming to the clinical features, we have seen the etiology, we have seen the pathophysiology. All these three almost have similar presentations. So present beyond the first week of ICU in patients having SIRS, MODS, or patient on high doses of corticosteroids or neuromuscular blockage agent. The involvement in the lower limbs is greater as compared to the upper limbs. So criteria for diagnosing the ICU-acquired weakness is weakness developing after. After is important. The onset of critical illness. Weakness is generalized. Both the involvement of proximal and distal muscles is being there. It is a symmetrical involvement. There is flaccid involvement, and it generally spares the cranial nerves. So facial grimace is intact. So cause of the weakness is not related to the underlying critical illness, and it should be excluded. So based on the MRC score, what is MRC? It is the muscle power score that has been given by the Medical Research Council. So a sum score of less than 48 noted on greater than 2 occasions that is being done 24 hours apart, or if the patient is on dependent on mechanical ventilation. So these are the criteria to diagnose all three. So earliest sign may be a facial grimacing without the limb movement. Extraocular muscle involvement is rare and muscle wasting is invariable. When you do an accurate sensory examination, it can be possibly normal in cases of a CIM with sensory loss of pain, temperature, and vibration sense in case of CIP. So DTR, deep tendon reflex, is usually normal, or it can be reduced in cases of pure CIM or absent in cases of CIP. So modified research council, that is the muscle power score, how it is being calculated. So it involves the assessment of muscle power from the 3 movements of each limb. What are those movements? You do a shoulder abduction of the patient, whether the patient is able to do elbow flexion or wrist extension or not, whether there is a hip flexion, whether there is a knee extension, and an ankle dorsiflexion. So you calculate based on the movement of all these joints and muscles, you calculate a maximum power, and this maximal power is graded according to this MRC scale. So a total score of 60 is being calculated when you calculate all these scores, and a score less than, which we discussed, 40, yes, this is the 48, is to be a criteria for diagnosing the ICU-acquired muscle weakness. So the basic steps in evaluation is you assess the weakness of the patient, you assess his muscle strength through the MRC muscle power score, you review the pre-hospital functional status, patient and family history should be taken into consideration, and search for the factors that is being associated with neuromuscular weakness. What are those factors? Whether the patient is exposed to glucocorticoids, whether there is a hyperglycemia, whether there is SIRS, sepsis, MODS in the patient or not. So this is basically MRC, muscle power strength score, which is being calculated. So a score of 0 in an awake and a cooperative patient with unfettered ability to voluntarily move the limbs, muscle strength can be calculated based on this MRC scale. So a score of 0 means no contraction, and a score of 5 means that normal power of the muscles is being there. Score of 3, active movements against the gravity. Score of 4, it is both against the gravity and against the resistance. So CIM can be distinguished from CIP if preservation of the sensory function can be demonstrated. So when you plan an investigation, first thing to decide whether the weakness was present during the onset or developed after a period of critical illness. So muscle biopsy, nerve biopsy, or both can only be indicated if you are not diagnostically, uncertain, and again, not indicated specifically for the diagnosis of all these three phenomena. So until and unless you rule out all the probable etiology, you rule out all the other causes, you don't just go straight away for a muscle or a nerve biopsy. Neuroimaging is indicated if the neurological assessment of the weakness is unreliable or if the evaluation reveals evidence that raises the suspicion for a CNS region. So you can do a serum creatinine kinase level in all patients who have critical illness that is associated with weakness. What exactly it reveals? Serum creatinine kinase, why exactly it rises? And that also we do in case of, if there is any cardiology parameters. Creatinine kinase in the muscles that get released into the circulation if there is a lot of muscle breakdown. So an elevation is usually present in a patient with CIM in a myopathy and supports the diagnosis. But again, it can occur in the absence of CIM patients also, those who are being treated with intravenous glucocorticoids. So you can go for a creatinine kinase estimation. Lumbar puncture, CSF, you have to rule out other causes. If it is the encephalitis, myelopathies, acute motor axonal neuropathy. Why? Because if it has been developed due to GBS. EEG, electroencephalography, in patients with altered consciousness to evaluate for seizures. So until and unless, muscle biopsy is not being able to perform or not being really performed, such as if you are considering an inflammatory myopathy as one of the differentials. So for patients with CIM or a combined muscle biopsy and histopathology, confirm the presence of myopathy. But in CIP, muscle biopsy findings are those with neurogenic atrophy. Okay. Electromyography. So a motor response that is being induced. How? This is being induced by the transcutaneous stimulation of the peripheral nerves and compound muscle action potentials from the corresponding distal muscles are being recorded. So to calculate motor nerve conduction velocity, stimulation at 2 points along the nerves is being required. Abnormalities in motor and sensory nerve conduction point to a neuropathic process is being done, and a sensory or mixed nerve potentials are being obtained respectively with the recording electrodes. So there are electrodes that are being applied and transcutaneous stimulation of the peripheral nerves is being done. And simultaneously compound muscle action potentials from the corresponding distal muscles are being recorded. So as CIP is a primary axonal neuropathy, CMAP and nerve action potential amplitudes are characteristically reduced, whereas conduction velocity, distal motor latencies, and responses to repetitive nerve stimulation are normal. So a sensory conduction examination might show you a decreased sensory nerve action potential amplitudes, which confirms the presence of polyneuropathy. So electroneuropathy, what you do, electrophysiological features of ICU-acquired for a CIP, it can be a normal to minimal reduction, be a reduction in the CMAP at amplitude, there can be a reduced SNAP amplitude. But what exactly are the findings in critical illness myopathy? There is reduced CMAP amplitude, there is increased but duration of the CMAP. But SNAP amplitude is normal in case of critical illness myopathy as compared to critical illness polyneuropathy. But there is reduced muscle excitability on the direct stimulation. Electromyography, you insert a monopolar or bipolar needle electrode into the skeletal muscle, and what you do, a spontaneous insertion activity is being assessed. So a needle electrode insertion into a normal muscle induces a burst of the insertion activity, but no obvious spontaneous activity. But if spontaneous activity like fibrillation potentials and positive sharp waves, that indicates denervation or myonecrosis, both of which separates the muscle fibers from their end plate zone. Step 2, what you do? You record a low threshold firing motor unit potentials, even with the slight movement or voluntary activation of the muscle. So the duration, amplitude, and number of phases is being assessed. So if it is a case of myopathy, these motor unit potentials, that is the MUPs or MUPs, are of short and low amplitude. In third step, you assess the response to the maximal voluntary contraction. So increase the force of voluntary contraction, increases the firing rate, and it produces a systemic recruitment of additional MUPs. So in healthy individuals, a large number of overlapping MUPs are being recorded at a maximal effort, creating a so-called interference pattern which is being there. So loss of functional motor units with axonal injury or conduction block produces a reduced recruitment interference pattern. Individuals with myopathic diseases such as CIM have the normal complement of motor units, but reduced number of functional muscle fibers, which results in normal interference pattern with decreased amplitude. So you go for a electromyography if it is a normal trace. Individuals who are having myopathic diseases with CIM can have a normal interference pattern, but with a decreased amplitude. So the voluntary recruitment of motor units is often impossible because the muscle is too weak. The patient is not able to cooperate. CIP, CIM both lead to reduction in the amplitude of CMAMs, and the use of snap alterations to discriminate neuropathies from myopathies can be problematic because many of the patients can be suffering from peripheral edema. You can also go for a direct muscle stimulation. What exactly you do in this? This can be applied in sedated patients. So motor action potential are being calculated through the stimulation of the nerves, through the nerve stimulation. So you assess the motor action potentials through the nerve stimulation, and direct muscle stimulation is being done. So by analyzing the amplitudes of two responses, a ratio between the CMAP and the DCMAP can be calculated accordingly. So based on this, you do a direct muscle stimulation, and by analyzing the amplitudes of these two responses, a ratio between the CMAP and DCMAP can be calculated accordingly. So a ratio of CMAP is to DCMAP ratio greater than equal to 1 suggests either a myopathy or a normal clinical picture. Differentiation between the CIM and the normal muscle function can be easily accomplished on the basis of what? On the basis of absolute value of DCMAP amplitude. So you calculate a ratio of ni is to dm, and if this ratio is greater than equal to 1, it can suggest either a myopathy or it can be a normal clinical picture. But if the ratio is less than 1, it usually arises in cases of neuropathy. So you calculate after nerve stimulation and direct muscle stimulation, that is the NE is to DM, and you calculate the ratio between NE is to DM. So what you do in the evaluation of, in the evaluation, you interrupt the use of sedatives and analgesics if the patient is on neuromuscular blocking agents. So you reduce the effect of sedatives, the patient awake, the patient is able to follow instructions or not. You assess the MRC score based on the grade of 0 to 5. If you are able to assess it, you are not able to assess the MRC score. If you are not able to assess it, continue to withhold sedatives. Maybe the patient needs more tapering down of the sedatives and analgesics. Assess the MRC score. If it is a normal findings, continue with the physical and occupational therapy and put the patient on observation. But if, which we discussed, a normal score is 60, greater than 60, the total score is 60. But if that score is less than 48, that indicates a symmetric weakness. So if you calculate the score, if that score is less than 48, you do a serial examinations, you go for a physical and occupational therapy. If there is improvement, continue it. But if there is no improvement, go for nerve conduction study, go for electromyography, and plan a muscle biopsy. If there is a focal deficit, that is deficit in either peripheral neuromuscular system or a deficit in central nervous system, so go for CT or MRI of the brain, or go for a EEG or CSF studies. So continue to withhold sedatives or analgesics, patient remain unresponsive. Again, if you continue to withhold, go for a CT and MRI of the brain accordingly. So you perform NCS, you perform EMG, you perform muscle biopsy. If there is preserved nerve conduction velocity, no demyelination, there is reduced amplitude of motor and compound sensory nerve action potentials, that means there is critical illness polyneuropathy. If there is reduced amplitude and increased duration of compound muscle action potentials, there is selective loss of thick filaments in muscle and fibers and muscle necrosis, that can indicate critical illness myopathy. So what are the differential diagnosis that you will build up according to the various lesions? Where is the lesions? Where is the disorders? So based on the brainstem lesions, you can categorize it. Maybe it can be a trauma, infarction, hemorrhage, abscess, central pontine myelinosis. If it is a spinal cord disorder, maybe spinal cord infarction, trauma, infective myelopathies, anterior horn cell disorders, motor neuron disease, poliomyelitis, polyradiculopathies, HIV or carcinomatosis, peripheral nerve disorders, GBS, polypheric neuropathy, paraneoplastic neuropathy, neuromuscular junction disorders like myasthenia gravis, Lambert-Eaton myasthenic syndrome, botulism, and a muscle disorder, rhabdomyolysis, diffuse myopathy, cachexia, mitochondrial myopathies can be there. So based on that, you build a lot of differentials. So disease and syndrome causing weakness, very important. GBS, why? Autoimmune mechanism, myelin loss is being there, that leads to autonomic instability, there is ascending paralysis, and of course, ventilatory failure. Vasculitic neuropathy, occlusion of the vasa vasorum, that leads to numbness, pain, and weakness in the muscles. Cervical myelopathy, that also leads to paresthesia, numbness, pain, and weakness. If there is a botulism toxin, that can lead to bladder dysfunction, descending paralysis, autonomic dysfunction. Porphyria, Lambert-Eaton syndrome, that leads to proximal weakness. ALS, amyotrophic lateral sclerosis, because of the bulbar involvement, myasthenia gravis, and porphyria. So these are the various disease and syndromes that can cause weakness in the patients of ICU. If you go for a histopathological features of CIP, you will show signs of axonal degeneration. But in CIM, muscle biopsies are considered to be the gold standard. Morphologically, you can, they have been grouped into the three types which we had talked about: quadrilegic myopathy, quadriplegic, thick filament. So in minimal change or cachexic myopathy, the muscle fibers show caliber variations, angulations. Necrotizing myopathy is characterized by muscle fiber vacuolization and phagocytosis of myocytes. So these are the various studies that has been done, which shows you corticosteroids use, an intensive care unit acquired weakness, a systemic review and meta-analysis. So conclusions, what was with them? There was significant association between corticosteroid use and ICU-acquired weakness. So therefore, the use of corticosteroids should be done cautiously, should be limited, or the administration time should be shortened to reduce the risk of ICU-acquired weakness. Impact of intensive insulin therapy on neurovascular complications and ventilator dependency. So the effect of intensive versus the conventional insulin therapy has been prospectively studied in surgical and medical ICU patients. What was the conclusion? So, a subset of medical patients in the ICU who were there for greater than equal to 7 days and on intensive insulin therapy, there were reduced incidence of CIP and CIM and were treated with prolonged mechanical ventilation less frequently. Why? Because of the prevention of hyperglycemia that can lead to triggering of the stress. So these strategies like, nutritional intervention, supplementation with arginine, omega-3 fatty acids, early mobilization, and physiotherapy could improve outcomes in patients with CIP and CIM. But again, there is a long list of possibility and open debates, which is being always there. So CIM is usually reversible over weeks and months. Rehabilitation is important. Patients who survive respiratory circulatory failure have the greatest frequency and intensity, up to 65% functional limitations who are being discharged from the hospital. So investigations for this CPK we have discussed, and what exactly will be the parameters. It can be normal or mildly elevated in CIP, but in CIM it is elevated. CSF, normal cell counts in CIP, or sometimes slightly elevated protein if it is a combined. Nerve conduction studies reduce CMAP, reduce SNAP, but in this CIM it is a normal SLAP which we have discussed. But if it is a combined, there is reduced CMAP and there is reduced SNAP also. EMG, electromyography, spontaneous fibrillation potential, sharp waves in CIP and CIM, and features of both is being present in CINM. Direct muscle stimulation, if you do in CIP, nerve muscle ratio is less than 5, but in CIM it is greater than equal to 5, and in CINM it is variable depending upon the cause. Muscle biopsy will show you features of denervation, muscle atrophy, but in CIM there will be thick filament myopathy, loss of myosin filaments, and necrotizing myopathy, the subtypes of them. Nerve biopsy can be normal or sensory or motor nerve axonal degeneration, but in myopathy it will be normal. In CINM it can be either a normal or reduced. This we have already discussed. Diagnostic criteria of CIP: either patient meets the criteria of ICU-acquired weakness, CMAP amplitudes decrease to less than 80, SNAP amplitude decrease to less than 80 of the normal values, near or normal nerve conduction velocities, and the absence of a decremental response on repetitive nerve stimulation. For myopathy, patient meets the criteria, SNAP amplitudes greater than 80%, electromyography in greater than equal to 2 muscle groups, with low amplitude MUPS, direct nerve stimulation greater than 0.5, and muscle biopsy, muscle histology that is consistent with the myopathy. Combination criteria for ICU-acquired weakness meets the criteria of polyneuropathy, meets the criteria of myopathy. So no intervention have shown to improve the outcome. So what is the aim for this? To prevent the development of ICU-acquired weakness. Rehabilitation, very much important. So mainstay: minimize the risk factors. Insulin therapy, you have to maintain the blood sugar levels in the range of 80 to 100. When you go for a nice UK study, the aim is random blood glucose level should be less than 215 in ICU-acquired weakness. So no specific therapy. The aggressive treatment of sepsis has to be done. Neuromuscular blocking agents and corticosteroids should be used in minimal doses and also for a short period of time. Okay, that is very much important. So routine features, general care, limiting use of the sedation, immobilization is very much important. There was a study for a cohort of survivors of acute respiratory distress syndrome for 5 years after the hospital discharge. So muscle weakness and functional impairment were frequently observed at period of 1 year, and recovery from the physical dysfunction was incomplete even 5 years after the discharge. So elderly survivors of critical illness appear to fare particularly poorly, and at the 5-year assessment, the result of 6-minute walk test were still only 70% of the predicted results. Preventive strategies: limit the use of neuromuscular blocking agents, limit the use of corticosteroids, early mobilization, maintaining proper glucose control has to be done. These are the various, reviews that has been done. Further research, there is a long list of, debate and open discussions that has to be done. And still the trials has been done that shows that, intensive insulin therapy reduces the CIP and CIM, and high quality evidence has been there that even reduces the duration of mechanical ventilation, even ICU stay, and 180-day mortality. Moderate quality evidence suggesting no effect of corticosteroids, and high quality evidence that shows that steroids do not affect the secondary outcomes except for fewer new shock episodes. Potential benefit of early rehabilitation, also having a shorter effect on the shorter duration of mechanical ventilation, and low quality evidence suggesting no effect on the on the EMS. But again, large random controlled trials need to be conducted to explore more and more roles of the electrical nerve muscle stimulation and early rehabilitation to promote more of the preventive strategies. When we talked about the prognosis, 45% of the patients diagnosed with this die within their hospital admission, with a further 20% within the first year after ICU start. So big number. An ICU-acquired weakness with severe exacerbation, which we have discussed previously only, with a mortality of almost 11%. Persistent severe disability is being seen close to 28%, and complete functional recovery occurs in almost about 68% of the patient only. So there was a history, there was a clinical case, there was a 46-year-old female having a history of right valvular heart disease, severe MS back in 2012 with a severe LV dysfunction, and she was advised medical management with, mitral valve replacement. Came to us with complaints of breathlessness, palpitations, ECG shows arterial fibrillations, RHD was made with severe MS with severe left ventricular dysfunctions. So patients has received 2 cycles of, hemodialysis, developed shock, and was transferred to the higher care for further management. So on the ER emergency, the patient was unresponsive. The patient was having hypoglycemia. The patient was bradycardia. The patient was given adrenaline. The patient was, intubated, mechanically ventilated, put on VRVC mode, was admitted in the ICU, but CPR was not being calculated. So there was a differential diagnosis of hepatitis, acute kidney injury, metabolic encephalopathy, cardiogenic shock were put into picture. On examination, the patient was comatose. There was hypotonia, which was present in all the 4 limbs. The reflexes was being absent. And after, a diagnosis of metabolic encephalopathy, hepatic ischemic encephalopathy was being made. After 4 days, somewhat of eye opening was present in the patient. A quadriparesis, absent of tone in all the 4 links presented. MRI of the brain done, which shows normal small vessel ischemic changes. And neuroreference was done, which showed hypotonia disproportionate to the MRI findings. So a nerve conduction study, a nerve conduction was performed, and nerve conduction velocity study showed amplitude of camps without conduction slowing or prolonging latencies. So diagnosis of critical illness, myopathy, and combined CINM was being made. Later in the hospital, patient developed fever. The blood culture showed growth of fungus with Acinetobacter. MRI brain was being done, which suggested again vertebral artery occlusions with cortical edema, and AKI was already being present. So patient went into shock, put on vasopressor support. Bradycardia was there. The patient was given CPR. There was return of spontaneous circulation, but again, definitive all the efforts, all the management, the patient went into cardiac arrest again and could not be survived. So the whole and soul, reference or clinical summary from this clinical case is being there that, the patient was already there, and maybe with the development of, with the ICU stay for greater than equal to 7, patient developed critically illness acquired myopathy with neuropathy. But one thing that has to be understood here is, was the patient developed this before coming to the hospital or developed after the admission of the hospital? So this is the overall clinical summary.